Good morning, everyone. I would like to thank the NASL for giving me this opportunity to present my thesis titled Does Guiding Antimicrobials with Gut Colonizing Bacteria and Expert Carba Improves Outcome in Hospitalized Cirrhosis Patients with Infections? A pragmatic randomized trial named Expert Gut Trial under the supervision of Dr. Nipun Verma. As we understand, infection leads to increased mortality in cirrhosis as high as 75% in ACLF, and early treatment of these infections lower mortality and improves outcome as demonstrated in the PREDICT study. Also, each hour delay in antibiotics increases the odds of death by 1.86 times. While we understand adequate treatment is important, existing guidelines fail to address the high burden of MDR infections in the Indian setting. Recently, a global study demonstrated huge burden of multi-drug resistant bacterial infections with 73% and 33% being XDR among the patients with cirrhosis in India. This was replicated in our large single-center study demonstrating the burden of 70% of multi-drug resistant organism infections. Interestingly, carbapenem-resistant bacterial infections was to tune of 48%, essentially leading to failure of empirical antibiotics as per the guidelines. In order to understand whether cirrhosis patients are predisposed to MDR infections, a group has demonstrated that the multi-drug resistant bacterial colonization as a risk factor for drug-resistant infections with an odds ratio of 8.45. Moreover, the concordance between the clinically infected specimens with the colonization was near about 76%, which was much higher than the previous studies. Recently, based on the surviving sepsis and IDSA guidelines, rectal colonization has been advocated as a guide to manage empirical antibiotics, especially in patients with culture negativity. So, therefore, we hypothesize that whether the utilization of this gut colonizing bacteria through conventional microbial cultures and expert CABA can guide our antimicrobial decisions and improve outcomes in patients with cirrhosis and systemic infections. So, PICO of our study was hospitalized cirrhosis patients with infections. We intervened through surveillance swab cultures in the form of rectal swab and expert CABA testing and utilizing this information to guide medical care and antibiotics. Standard of care was our comparator, and our primary outcome was comparing overall survival at 28 days, and secondary outcomes were comparing the changes in resolution of index infection, change in disease severity scores, evolution of organ failures, length of hospital stay, and cost of hospital stay. So we recruited cirrhotic patients with bacterial infections as per the European guidelines. They were randomly allocated in 1-to-1 ratio to intervention and control group using computer-generated random number tables with allocation concealment through SNOWs. In intervention group, within the 12 hours of infection diagnosis, in addition to the standard procedures, we tested for the rectal swab through standard cultures and rapid molecular test named Expert CABA. Based on these results, we guided the medical care and antimicrobials such as ceftazidime-avibactam with estrinam in carbapenem-resistant organisms. We provided guidance document to the treating physicians regarding the choice of antimicrobials according to the results of expert CARBA and cultures as per the ICMR and IDSA guidelines, along with standard hand hygiene and maintenance bundle guidelines. Regular follow-up was done every third day till 28th day to assess the primary and secondary outcomes as described before. So our sample size was 100 patients with 50 patients in each group, and conventional statistics was used with Cox regression analysis for survival analysis, and standard statistical tests were utilized. CETRI registration was done before initiating this trial. So as we can see in the consort diagram of 166 patient screen, 101 patients were randomized into the intervention and the control arm. All patients received allocated intervention or the standard of care in both the groups and were followed up till the 28 days. Only one patient was lost to follow-up at the end of 26 days in the intervention arm. All patients were included as per the intention to treat analysis. Baseline data was similar, including the age, gender, etiology, which was predominantly ethanol. About 70% patients were ACLF at baseline. Severity scores at admissions were comparable. However, intervention arm was slightly sicker in the form of CLIF COF and SOFC scores. Lung was predominant site of infections, followed by peritoneal, and most of these infections were healthcare-associated infections. So expert CARBA testing showed carbapenemase positivity in 85% patients, predominantly mediated by new teleproteinase, which was common to all. Swab cultures results replicated the similar finding in the form of carbapenem-resistant Enterobacteriaceae and Acinetobacter baumannii. Some patients also had vancomycin-resistant Enterococci and drug-resistant Staphylococcus. Baseline antibiotics were largely ceftriaxone, piperacillin, tazobactam, and meropenem. with the teicoplanin, which was comparable between the two groups. After rectal swab testing, 90% patients in the intervention arm with carbapenemase positivity were escalated to ceftazidime avibactam with estrinam or polymyxin-based therapies. While in the control group, antibiotics were escalated as per the clinician judgment and only preterminally escalated to polymyxins beyond 7 to 10 days. And with this, we could demonstrate significant improvement in the survival and intervention arm with a hazard ratio of 0.53 and a number needed to treat as a 4. Further, the hazard of mortality remained lower in the intervention group when adjusted for the potential confounders and disease severity, including the CLIF COF, MELD, time from admission to enrollment, and the site of infections. Resolution of index infection was much better in the intervention arm, and this was reflected in the procalcitonin levels in the intervention arm. Improvement. We could also demonstrate improvement in the severity scores with a significant worsening in the control arm and improvement in the intervention arm. The rate of change of severity score was noted through mixed effect regression models, which could demonstrate improvement in MELD, MELD-NA, and CLIF COF scores over time in intervention as compared to the control arm. Looking at the specific organ failures, we could see there was a significant reduction in proportion of patients with cardiovascular, cerebral, and the respiratory failures in the intervention group compared to the control group. Length of stay was not different between the two groups, and the intervention arm posed an excess amount of pocket of expenditure, 3,600 rupees per each death averted. Attributable mortality was calculated to the index infection, which was significantly lower in intervention arm as compared to the control arm with a hazard ratio of 0.5. Similarly, attributable mortality to the second and fungal infection was lower in the intervention arm. Cumulative proportion of second and fungal infection was trend higher in control arm but was comparable and not statistically significant. Serious adverse events were more prevalent in the control arm compared to the intervention arm, with a significant difference largely because of the death count, which was higher in the control arms. However, non-serious adverse events were similar between the arms. So, as we can see, this is the first randomized trial demonstrating the utility of expert carbar and rectal colonization as a guide for management of infection in cirrhosis by rapid diagnostics and better antimicrobial decisions. Such approach can have improved survival, better infection resolution for an incremental amount of 3,600 rupees per death aversion. So limitations of study include single center trial that needs multicentric validation, and there's a potential concern of overuse of antimicrobials with blind treatment with higher end antimicrobials which can be further curtailed through rapid molecular diagnostic testings and in select individuals not improving on standard antimicrobial therapy with culture negativity. So this study demonstrated that the implementation of rapid molecular diagnostic test and targeted antimicrobial therapy in infected cirrhosis patients guided by rectal colonization can improve the survival, infection resolution, and organ failures. So in the end, we would like to extend our sincere gratitude to CEPHID for generous donations of rectal swab testing supply and to Zydus for providing ceftazidime avibactam and estrinam free of charge to our patients. And in the end, I would like to thank the Department of Hepatology of PGMR Chandigarh along with the teams of Department of Microbiology and Pharmacology. Without their support, this study wouldn't have been possible. Thank you so much.
In your series, what was the correlation between carbapenem resistance in the stool versus the bacteria which you grew from from the rectal swab compared to whatever you grew from acetic fluid or blood? Or
Yes, sir. So we had culture positivity of around 25 patients, which was about, and 18 patients had MDRO infections, which was about 70%. Though we tested those infections for the expert carbar, but because we think with there was less infection and less microbial load in these cultures and these specimens, it was not growing any result on the expert carbar. So that was tested, but it could not be proved that the multi-drug resistant infections in the culture clinically specimens
was not correlating well with your rectal swab.
These were, we didn't test it for these clinically infected culture specimens. We tested them, but they didn't grow anything because I think the microbial culture load was very low in these infected cultures.
So you don't know whether there was
we don't know about these specimens.
And secondly, you said 12-hour gap to antibiotic therapy in your group. This is not the recommendation. Anyway,
Yes.
Was there a difference between your control group and your treatment group with regard to starting of antibiotics, the time of starting antibiotic? Was there a difference? Or you waited for everybody for 12 hours?
Thank you, sir. In our cohort, all the patients were already on antibiotics from the emergency or from the department while we recruited these patients. So baseline and enrollment, as we can see, antibiotics were largely ceftriaxone, piperacillin, tazobactam, meropenem, and ticoplanin. We waited for 12 hours because it is a pragmatic real-world study.
No, did you wait for everybody for 12 hours?
We didn't. We didn't wait for it. We just calculated like it was maximum of up to 12 hours. So being it a real-world pragmatic nature of the study, it was like
microphone one.
Thank you. Dr. Agarwal, I am actually extremely worried because the message that goes out is that we should start using complex antibiotics at the first go. My concern is that the hypothesis would be that any bacteria in the gut, if it has a resistance gene, then the infection causing bacterium, which is possibly just one bacterium, is also having drug resistance. Is there a theoretical basis for this? And that's where I think the question, what was the relationship? And the second concern I have is, in 34 patients you ended up giving complex antibiotics. Why do stool? Why not just go ahead and give it to everybody in 50? If you can increase to 34, go to 50.
So for the first question, as we have seen in the last day also, gut dysbiosis is increased in the due to immune dysfunction in the ACLF patients as the ACLF grade is higher. And if we give these antibiotics to every patient, this would lead to overuse of newer antimicrobials. But if there's any guide to treatment and to support that this can be done because of this, we have showed any multi-drug resistant infection anywhere in the colonization, then this would be more ethical for giving these antibiotics.
Sorry, I think we cannot say that this is more ethical or unethical. Sorry.
Okay. One brief 2 questions to you. We have limited time. Do you have a protocol? 36% had your CRE. So what is the protocol for them? What is the protocol for other organisms?
I didn't understand the question.
You have the resistance, you have done the stool microbes.
Yes, sir.
And then you have X, Y, Z groups. So
Yes,
do
sir.
you have a protocol which you propagate? Which group will get what antibiotic?
No, sir, we didn't had any, we just had 2 groups, the intervention and control group. In intervention, we tested for rectal colonization, which harbor, if
Did it change your practice doing the test?
sir, yet it is not, we have not utilized in this practice, but we may utilize in
So we
this practice
don't know
in
the
future.
practice and the outcome. And what is the nutritional inputs in these, in your study? Like you are saying, do a stool test and change back. It's not a switch on, switch off, 1:1, cause and effect. So I want to know one thing is the nutrition of these patients.
Sir, nutrition...
Were they being fed by some amino acids?
No, sir. Nutrition was only the hospital-based diet, and it was similar for both the groups, control and intervention.
At admission?
At admission too, and sir, the nutrition was not different in
Now,
both the
did you
groups.
check for it when
Yes,
they
sir.
entered the emergency? Is there a data where you had taken nutritional
No,
history?
sir, we didn't check in the emergency. We checked the nutrition when the patient was enrolled in our trial at the baseline.
Okay. Thank you.
Thank you, sir.